Hello, everyone, and welcome to our module on dementia. So, dementia is a disorder that involves a gradual decline in cognition. And one of the key words here is gradual. As we'll talk about shortly in this video, most causes of dementia lead to a decline in cognitive function that occurs very slowly over months or years. Importantly, there's no change in the level of consciousness. Patients do not lose consciousness associated with dementia. They simply have problems with cognition. Some of the problems that patients can have specifically are memory deficits. We'll talk about this in a second. Executive function deficits, which we'll also talk about shortly. And then in advanced stages, patients with dementia can have personality changes. They can become listless or they can become agitated. Usually dementia is irreversible, although there are a few exceptions. And this is a distinction from delirium, which I talk about in another video. Delirium is always reversible. And the EEG is usually normal in dementia, except in some rare instances. And this is also a distinction from delirium. In delirium, the EEG is usually abnormal. So I said on the last slide that memory deficits are one of the key features of dementia. So let's talk about this now. So the greatest effect of dementia is on short-term memory. So patients with dementia have difficulty forming new memories, recalling recent events. When you talk to a patient with dementia, they will often ask you the same question over and over because they don't remember that you just answered it a minute ago. They will also forget things like appointments. So this is all related to problems with short-term memory. Long-term memory, in contrast, is often intact. Many patients with dementia can still remember where they were born or things from their childhood, but they forget something that you just told them a few moments earlier. Also, we mentioned a few slides ago that deficits in so-called executive function are part of dementia. So let's talk about what we mean by that now. So things that fall under the heading of executive functions are things like planning your day, or organizing your bedroom, or organizing your office, problem solving or multitasking, or knowing not to engage in inappropriate behaviors. All these things are part of executive function, and they can be lost in patients who have dementia. And so this leads to things like inability to follow a recipe. That's something that's very hard for a person with dementia to do. Or inability to manage their finances. This is something that happens to many elderly patients when they develop dementia. Or inability to navigate a familiar route when you're walking or driving a car. All these things are examples of executive function deficits. I said at the beginning of this video that most causes of dementia are irreversible, but there are a small number of reversible causes, and I've listed some of the important ones on this slide. These are high yield to know, not just for your STEP exams, but also for clinical practice. Common question that's asked of medical students on rounds is to name some of the reversible causes of dementia. A big one is depression. I talk about this in videos in the psychiatry section, but patients with depression can become listless and they can appear to be demented, and this is called pseudodementia and has to be distinguished from true dementia. Hypothyroidism and vitamin B12 deficiency are two classic reversible causes of dementia, and so for this reason, when patients present with new onset cognitive decline, a TSH level and a B12 level are often measured. Normal pressure hydrocephalus can cause dementia. It's reversible if you bring down the pressure in the spinal column. I talk about this in other videos. Neurosyphilis is a treatable cause of dementia. And then finally, there are a number of medications that can cause cognitive decline. These medications are summarized in what's known as the Beers criteria, which is a list of meds that can cause cognitive decline, and I talk about this in detail in the video on delirium. Okay, so those are the reversible causes of dementia. For the rest of this video, I'm going to talk about the other causes of dementia. Most of these are not reversible. The biggest one is Alzheimer's disease. This is the most common cause of dementia in the United States. It's responsible for about 60% of cases. After Alzheimer's disease, the next most common cause is vascular dementia. This refers to strokes that cause cognitive decline, and this is responsible for about 20% of cases. Another cause is Lewy body dementia, which we'll talk about in a second. And then these causes down here are very rare causes of dementia. We'll talk about frontotemporal dementia and Creutzfeldt-Jakob in this video. In other videos, I talk about HIV-associated dementia and Wilson's disease, but these things also can potentially cause dementia. And if you just remember this pie chart shown in the slide here, this pretty nicely summarizes the causes of dementia. Alzheimer's is the big one, followed by vascular dementia, then Lewy body and frontotemporal, and then you've got these other rare causes over here. Okay, so now let's talk about Alzheimer's disease. The most common cause of dementia is something you will definitely see if you rotate clinically in hospitals and clinics in the United States. Alzheimer's disease is caused by degeneration of the cortex. This means that the gyri narrow and the sulci widen in the cortex, and it's high yield to know these terms right here. To understand this, let's look at this cartoon on the slide here. So this is a healthy brain at the top of the slide here, And at the bottom is an example of what the brain and the cortex can look like in someone with advanced Alzheimer's. Notice that the sulci, the spaces between brain tissue, have widened. Notice also that the gyri, these little bumps of brain tissue, have narrowed. That's the narrowing of the gyri and the widening of the sulci, classic for Alzheimer's disease. This is all related to degeneration of cortical brain tissue. Another classic finding in Alzheimer's disease is hydrocephalus ex vacuo. This refers to ventricles that are enlarged because of neuronal loss and atrophy, not because of elevated CSF pressure, which is the usual cause of hydrocephalus. And so once again, if you look at this drawing of a brain with a patient who has Alzheimer's disease, the ventricles are enormous compared to the normal ventricles up at the top. That's hydrocephalus ex vacuo. You can see that in any degenerative cortical brain disease. It's classic for Alzheimer's. You can also see it in frontotemporal dementia, which we'll talk about later. You can also see it in Huntington's disease. And then finally, you should be aware that the loss of neurons in Alzheimer's disease is generalized throughout the cortex. It doesn't occur in any one specific region, so you usually do not see focal deficits like arm weakness or leg weakness because you don't have a focal area of neurons being lost. You have a little bit of neurons from lots of different places being lost, and that leads to no focal deficits. The main problem is with cognition. If you're going to be taking the USMLE Step 1 exam, it's very high yield to remember that Alzheimer's disease is associated with loss of acetylcholine cortical activity. So acetylcholine is a neurotransmitter. It's used by neurons in the central nervous system, including in the cerebral cortex. And in Alzheimer's disease, neurons that release acetylcholine are lost. Not only this, the neurons that are maintained have a deficiency of choline acetyltransferase, which is an enzyme that synthesizes acetylcholine. So this further worsens the loss of acetylcholine activity in the cortex, and that's a major feature of Alzheimer's disease. Some of the regions of the brain where this loss of acetylcholine neurons has been well documented are, first of all, the basal nucleus of Meynert. This is a region of the subcortex that I talk about in the video on neurotransmitters, but it's where most of the acetylcholine for the central nervous system is produced, and from there it's transmitted to other places where neurons use the neurotransmitter. So in this basal nucleus of Meynert, you see loss of acetylcholine-releasing neurons. You also see loss of acetylcholine neurons in the hippocampus. This is in the temporal lobe, and it's the region of the brain responsible for forming new memories. And so loss of acetylcholine secreting neurons here is believed to be part of why there are memory problems in patients who have Alzheimer's disease. Let's talk in a little bit more detail about the pathophysiology of Alzheimer's disease. So if you examine the brain tissue from the cortex of patients with Alzheimer's disease, what you will find is accumulation of proteins called alpha-beta amyloid. And it's believed that the accumulation of these proteins is what leads to Alzheimer's disease, although this isn't fully understood yet. The source of the alpha-beta amyloid plaques that you see in Alzheimer's disease is a protein called amyloid precursor protein, which is found on neurons. It gets cleaved into a breakdown product, which then goes on to form alpha-beta amyloid plaques. These build up in the brain, and that's believed to lead to Alzheimer's. This whole process that I've shown on the slide here is influenced by our cholesterol transport proteins called apolipoprotein E. Depending upon which form of apolipoprotein E a person has in their body serving as cholesterol transport proteins, that influences their risk of having this process occur in the brain and lead to Alzheimer's disease. There are three major alleles for apolipoprotein E in humans: the E3 allele, the E2 allele, and the E4 allele. The E3 allele is the most common allele, and it's neutral in terms of Alzheimer's risk. It doesn't increase or decrease the risk. Less commonly, people have the E2 allele, and that allele is protective against Alzheimer's. Basically, it inhibits this process that I've drawn on the slide here. And then the third allele is the E4 allele. This allele accelerates this process I've shown on the slide here, and therefore it's associated with more buildup of alpha-beta amyloid and an increased risk of Alzheimer's disease. Let me pause and talk briefly about the term amyloid in general. So amyloid refers to protein aggregates, basically accumulation of protein in tissues that is seen in many disease states. Amyloid deposits are always extracellular, and they always stain with the Congo red stain, and they have apple green birefringence when you look at these amyloid aggregates under polarized light. These are the hallmarks of amyloid protein buildup. The disease processes that occur from amyloid buildup depend on where the aggregates are found, and there's a condition called amyloidosis where you get amyloid deposition diffusely throughout the body, and I talk about that condition in detail in the hematology section. But in Alzheimer's disease, what you have are brain amyloid deposits. That's what's believed to lead to the cognitive decline of Alzheimer's disease. So in patients who have Alzheimer's disease, you can find extracellular deposits of amyloid protein. These deposits are called neuritic plaques. They're sometimes called senile plaques. You see them in the brain tissue of patients who have Alzheimer's disease. They're seen best with the silver stain. This is a picture of what they look like right here. This brown plaque in the middle of this cortical brain tissue is an amyloid plaque. And that's what you see in the brains of patients who have Alzheimer's disease. Besides amyloid plaques, there are two other pathologic findings in Alzheimer's disease you should be familiar with. So let's talk about these now. The first one is the presence of neurofibrillary tangles. So if you look at this slide shown on the screen here, this is brain tissue from someone who has Alzheimer's disease. These are neurons right here, and inside the neurons you can see these purple streaks. Those are neurofibrillary tangles. They are made up of hyperphosphorylated tau proteins inside of neurons. So what are tau proteins? Well, tau proteins are proteins in neurons associated with microtubules, and for reasons that are incompletely understood, these proteins become hyperphosphorylated in disease, and then they aggregate into these toxic insoluble fibrils that you can see on slides like in these two neurons here, and that's believed to be one of the things that leads to neuronal death in patients with Alzheimer's disease. The other pathfinding is the presence of hyaronobodies. These are intracellular eosinophilic rods, so they tend to have a red color. I don't have an example to show you, but you can Google this and see examples if you wish. Hyaronobodies are buildups of actin and cytoskeletal proteins, and they're caused by neuronal degeneration and stress. So basically, they're evidence of stress on neurons, and these hyaronobodies are often seen in neurons in the hippocampus in patients who have Alzheimer's disease. Let's talk about some of the risk factors for Alzheimer's disease. So the typical form of the disorder, the one that most of the patients you see will have, is called late onset Alzheimer's disease. And the major risk factor for this form of Alzheimer's is age over 65. Another important risk factor is apolipoprotein E4, which we talked about a few slides ago. There are, however, a small number of patients who develop early onset Alzheimer's disease, meaning before age 65. This is relatively uncommon. And usually when this happens, it means there's some genetic predisposition present in the patient. One of the things that can cause early onset Alzheimer's disease is Down syndrome. So children born with Down syndrome have 3 copies of chromosome 21, and the amyloid precursor protein that we just talked about is found on chromosome 21. So these children form more APP and therefore are more likely to form beta amyloid plaques in the brain, leading to Alzheimer's disease at an early age before 65. Beyond Down syndrome, there are a couple of gene mutations that are associated with early onset Alzheimer's. One of these is a mutation in the gene that codes for the amyloid precursor protein. There are also 2 proteins called presenilin 1 and 2. The genes that code for these proteins can have mutations that lead to Alzheimer's disease. Any mutation in any of the genes for these proteins here increases the formation of beta amyloid, and that's what you see in some rare familial forms of Alzheimer's disease, where patients in the family who inherit one of these mutated genes develops Alzheimer's at an early age. Let's talk about how Alzheimer's disease is diagnosed. So first of all, you should know that a classic scenario is that the patient doesn't notice their cognitive decline, and they're brought in by a family member who's worried about the patient becoming more forgetful or disorganized. In clinical practice, the diagnosis is usually made clinical in a patient who has typical features of Alzheimer's after you've ruled out other causes like B12 deficiency and thyroid disease. The only definitive method to make the diagnosis is through autopsy and to examine brain tissue and find evidence of beta amyloid plaques and other findings of Alzheimer's. Imaging is, however, sometimes done to find supportive evidence of Alzheimer's disease, even though it can't make the diagnosis. Some of the things you might see should be obvious to you now that we've talked about what happens to the brain in Alzheimer's disease. So you can see reduced hippocampal volume. You can see atrophy of the medial temporal lobe where the hippocampus is found. All this is related to the regions of the cortex that are involved in memory formation. There are some drug treatments that can be used for Alzheimer's disease, so let's talk about those now. The first group of drugs are the acetylcholinesterase inhibitors. These are drugs like donepezil, galantamine, and rivastigmine. All of these drugs inhibit the enzyme acetylcholinesterase, which breaks down acetylcholine, and so as a result, they increase acetylcholine activity in the central nervous system. Unfortunately, the effect of these drugs is minimal. They've been shown to temporarily improve some symptoms of Alzheimer's disease, but they don't alter the long-term disease course. And in terms of the step 1 exam, what you want to remember about these drugs is that they increase acetylcholine activity, and acetylcholine is the major neurotransmitter of the parasympathetic nervous system. So patients taking these drugs can see enhanced parasympathetic tone. This can lead to things that you would normally get when you have more activity of the parasympathetic nervous system. Things like bradycardia, AV block, decreased cardiac output, all of these can potentially occur when patients take these medicines for Alzheimer's disease. Another Alzheimer's medication is memantine. This is an NMDA receptor blocker. NMDA stands for N-methyl D-aspartate, and this is the receptor for the neurotransmitter glutamate. One of the hypotheses about how the neuronal damage in Alzheimer's disease occurs is that you have excess glutamate activity, which overstimulates NMDA receptors. This leads to a toxic process called excitotoxicity. Basically, neurons are overexcited and they have excessive calcium influx, and this leads to neuronal damage. So memantine was designed to inhibit this process by blocking the NMDA receptor. And just like the cholinesterase inhibitors, it has some limited evidence of short-term benefit, but it doesn't alter the long-term course of Alzheimer's disease. Some of the side effects of this disease are dizziness. It's a very common side effect. Sometimes confusion. You can have confusion from Alzheimer's, but you can worsen confusion with this drug in some cases. And then very rarely, patients develop hallucinations. And then lastly, I'll mention that there are newer drugs that function as anti-amyloid monoclonal antibodies. These are antibodies designed to bind to amyloid plaques in the brain and stop them from growing. Drugs in this group include aducanumab and iacanumab. These drugs are new to the market and they're controversial because they're very expensive. They have to be administered by an infusion, and their impact on the symptoms and prognosis of Alzheimer's disease is modest. Okay, now let's move on from Alzheimer's disease and talk about the second most common cause of dementia, and that's vascular dementia. This occurs when patients have had multiple strokes or they have chronic ischemia to regions of the brain, leading to dementia clinical features. This form of dementia is usually suspected when patients have vascular disease risk factors, so things like hypertension, diabetes, high cholesterol, or smoking. And then a classic feature of vascular dementia is what's known as a stepwise progression of symptoms. So a patient will have a sudden abrupt onset of new dementia-type symptoms, followed by a period of stability, and then they will have another worsening of their symptoms. This stepwise progression is caused by small infarctions in the brain, so they don't have the slow, steady decline you see in Alzheimer's. Instead, it's a stepwise progression. The typical findings on CT scan or MRI of the head include multiple infarcts in different regions of the brain, and the treatment is to modify the risk factors to try and prevent additional strokes from causing worsening dementia. Okay, moving on, let's talk about dementia with Lewy bodies. And to start, let's define what a Lewy body is. So a Lewy body is a finding on examination of brain tissue. It's a round eosinophilic intracytoplasmic inclusion. This is a picture of a neuron with Lewy bodies at the tip of this arrow shown in the slide. And if you go to Google and you search up Lewy bodies, you'll see hundreds of pictures like this. You should do that so you get used to recognizing these structures in the brain. Lewy bodies develop in neurons, and they are made up of misfolded alpha-synuclein. It's high yield to know this. Alpha-synuclein is a neuronal protein. It's important for the release of neurotransmitters at synapses, and it becomes misfolded and accumulates, forming Lewy bodies, which then go on to cause Lewy body dementia. In the condition we're talking about now, dementia with Lewy bodies, you see Lewy bodies deposited in the cortex. In Parkinson's disease, you see Lewy bodies deposited in the basal ganglia. So you should be aware that Lewy bodies are a component of both this condition we're talking about now, dementia with Lewy bodies, and also Parkinson's disease. You also should know that even though it isn't commonly done, you can detect Lewy bodies in skin biopsies. There's a very special laboratory technique called real-time quaking-induced conversion, and this laboratory technique can detect alpha-synuclein in peripheral nerves that has accumulated, and therefore it can identify the presence of misfolded alpha-synuclein that leads to the formation of Lewy bodies in the brain. This disorder is sporadic, meaning it's not usually inherited or passed through families, and it's a late onset disorder. It usually occurs around 75 years of age, somewhat similar to the age when you see symptoms of Alzheimer's disease. The key features to be aware of for dementia with Lewy bodies is that patients will have typical dementia symptoms, just like you can see in Alzheimer's disease, but they will also have symptoms of Parkinson's disease, which I talk about in detail in another video. But this includes things like bradykinesia, which is difficulty starting movements, arresting tremor. Patients can have rigidity of joints and gait problems. All of these are symptoms you often associate with Parkinson's disease, and they occur concomitantly with dementia symptoms in patients who have dementia with Lewy bodies. Now, one thing that can be confusing is that a patient can have Parkinson's disease and years later develop dementia from Parkinson's disease, or they can have dementia with Lewy bodies where they develop dementia and Parkinson's disease at the same time. So clinically, there's this unofficial rule that's followed called the 1-year rule. And this says that if a patient has dementia symptoms before they've had Parkinson's for 1 year, then they have dementia with Lewy bodies. On the other hand, if they've had Parkinson's symptoms for at least 1 year before they get dementia, then what they have is Parkinson's disease complicated by dementia. But both disorders, Parkinson's disease and dementia with Lewy bodies, share the underlying Lewy body pathology, and that's why they often go together. Besides Parkinson's disease symptoms, there are some other special clinical features of dementia with Lewy bodies, so let's talk about these now. The first one is cognitive fluctuations. So this refers to a variability in the patient's attention and alertness that can change over minutes, hours, or days. So basically, the patient can be lucid and coherent one moment, and then confused and disoriented or even unresponsive the next. These are called cognitive fluctuations. You generally don't see this in other forms of dementia, especially Alzheimer's disease. You can see this in delirium, but fluctuations like this are not typical of dementia, but they do happen in patients who have dementia with Lewy bodies. Another potential clinical feature is visual hallucinations, and this is different from Alzheimer's, where hallucinations are very rare, but visual hallucinations, which can occur in delirium but usually don't occur in dementia, can be seen in dementia with Lewy bodies. And then lastly, dementia with Lewy bodies is associated with REM behavior sleep disorder. This is a type of sleep disorder called a parasomnia. I talk about these in other videos. But basically, patients who have dementia with Lewy bodies can act out their dreams and become very agitated at night during REM sleep. This is called REM behavior sleep disorder. Okay, moving on. Our next cause of dementia is frontotemporal dementia, also sometimes called Pick's disease. This is a very rare cause of early onset dementia, so it occurs in younger patients younger than 65, and this is different from Alzheimer's disease and vascular dementia and dementia with Lewy bodies, which occur in older patients. In this form of dementia, there's atrophy of the cortex that predominantly affects the frontal and temporal lobes. That's why it's called frontotemporal dementia. When the atrophy affects the frontal lobe, this can lead to changes in personality and behavior, and when it affects the temporal lobe, this can lead to speech problems and aphasia. So there are two subtypes of this disorder, and what they're going to want you to know for the Step 1 exam is which lobes of the brain each subtype is associated with. So the behavioral variant is associated with atrophy of the frontal lobe. This is the most common type of frontotemporal dementia. So with the behavioral variant, patients develop disinhibition. They can display socially inappropriate behavior. They can be apathetic and have a loss of empathy for other people. And then they also classically display hyperorality, which means using their mouth excessively. Usually this presents as altered food preferences and then wanting to eat things that they normally don't eat, but they want to eat them now in large quantities. The other variant is called primary progressive aphasia, and this is associated with atrophy of the temporal lobe because that's where our speech centers are found. So these patients have speech and language impairment. They can have halting speech or impaired word finding or other issues that fit with aphasia. And so these clinical features I've listed here on the slide, these tend to be the dominant clinical features. Other things that we often associate with dementia, like memory problems and executive function problems, those are usually preserved early on in the course of this disease, and it's these things right here that are the dominant clinical feature. When you examine the brain tissue of patients with frontotemporal dementia, there are two special pathology findings that you need to know about. So let's talk about these now. The first one is accumulation of the tau protein. So tau protein abnormally accumulates inside neurons in this form of dementia. Tau is a protein you normally find in neurons associated with microtubules, but what happens in frontotemporal dementia is it becomes hyperphosphorylated. It's high yield to remember this. Once the protein is hyperphosphorylated, it detaches from microtubules, and then it aggregates and forms clumps that are toxic insoluble fibrils, and this is thought to contribute to the death of neurons in the cortex in this form of dementia. The other special pathfinding is presence of TDP43. TDP43 is an RNA binding protein, and in frontotemporal dementia, it becomes phosphorylated and also ubiquinated. Ubiquination is a post-translational modification of proteins that I talk about in detail in videos in the cell biology section. But TDP43 undergoes phosphorylation and ubiquination, and after that, it aggregates and forms clumps of toxic cytoplasmic inclusions. This is a picture of what they look like on the slide here. They are these dark brown clumps that you can find in brain tissue of patients who have frontotemporal dementia. Okay, our final form of dementia we'll talk about is very, very rare. It's called Creutzfeldt-Jakob disease. Creutzfeldt-Jakob is a prion disease. So what is a prion? A prion is a misfolded protein that is also infectious. And what do I mean by infectious? I mean that it can induce abnormal folding of normal versions of the protein to create more of itself. As a result, it can transmit disease without using DNA or RNA, and this is very unusual. Most things that are capable of transmitting disease and copying themselves, most organisms that can do this, have DNA or RNA. Prions are a unique exception. They are purely proteins, but they can make more of themselves. Exposure to one of these toxic prion proteins leads to a rapidly progressive form of dementia, And the key phrase here is rapidly progressive. This type of dementia develops over weeks to months, not over years like Alzheimer's and other forms of dementia. A classic clinical feature of this disorder, and one that will almost certainly be described in a board question about this disease, is startle myoclonus. This refers to sudden involuntary muscle jerks. Those are myoclonus type activities that are triggered by a loud noise or some other abrupt stimulus. This is a classic feature seen in many patients with this disorder. And as I said, this is a very, very rare disorder. There are only about 1 to 2 cases per 1 million people worldwide each year. When you examine the brain tissue of patients with Creutzfeldt-Jakob disease, the classic finding is called spongiform encephalopathy. This is a picture of what it looks like on the slide here. Basically, microscopic vacuoles form inside of neurons. That's what a lot of these white spaces are here, vacuoles. You also get vacuolization of neuropils. So what's a neuropil? A neuropil is a meeting place of processes of different cells of the central nervous system. So it's a network of the processes, the little extensions of cells like dendrites and axons and other glial cells. So they come together and form these neuropils. And this is another place where you can see vacuolization, these open clearings here inside of brain tissue. Just so you understand how Creutzfeldt-Jakob disease develops, let's take a look at this diagram I've made on the slide here. So all of us have in our body a prion protein called PRPC. This is a normal protein that does not cause disease. But if we're exposed to the pathologic variant of this protein, which is called PRPSC, then that abnormal or pathologic variant can cause some of our normal protein to become abnormal. And then you get multiple copies of PRPSC, the abnormal protein. They start to come together and form beta-pleated sheets in the brain, and that's what leads to Creutzfeldt-Jakob disease. And so I've summarized these points on the slide. PRPC is the normal protein in humans. PRPSC is the pathologic variant. It can form beta-pleated sheets. It's also resistant to degradation by proteases, and it's capable of converting the normal protein into the pathologic protein, which is what I've shown here in the diagram. Usually, these abnormal proteins develop sporadically, but you can sometimes acquire them from exposure to something. The classic place where this can happen is from contaminated material, like from the operating room, if a patient just had surgery and had Creutzfeldt-Jakob disease. And in fact, when you do brain biopsies or other treatments involving surgery for patients with this disorder, there are special sterilization procedures that have to be followed to try and destroy the pathologic protein, because if any of it lingers, it can cause the disease in all the people working in the operating room. The gold standard for diagnosis of Creutzfeldt-Jakob disease is a brain biopsy, but there are suggestive findings you can see on EEG or in the cerebrospinal fluid. On EEG, the classic finding is called the presence of periodic sharp wave complexes. This is a picture of what they look like here, but don't try to memorize it. You're not going to be expected to interpret EEGs for the step exams. You just need to know the names of the classic findings. They're called periodic sharp wave complexes because they are high amplitude sharp waves that occur periodically, meaning every 0.5 to 2 seconds. And don't confuse this finding, which goes with Creutzfeldt-Jakob disease, with spike and wave discharges, which is a different finding that you see in children who have absence seizures. There's also a protein called the 1433 protein that you can identify by doing a lumbar puncture and taking a sample of CSF. This is a normal protein found in neurons, but higher levels of this protein are found in Creutzfeldt-Jakob disease. This is a nonspecific finding. It's just supportive of the disorder. It doesn't make the diagnosis. And as I mentioned earlier, Creutzfeldt-Jakob is unfortunately rapidly progressive, and it's usually fatal over a short period of time. And that concludes our module on dementia.